I was coming on to now, understanding patient selection, and this really is absolutely key, that we understand who we are likely to help with rehabilitation and who, quite frankly, are just beyond rehab. And we've already heard about this from Vipul, talked about the shape of the trochlea. You know, if we have someone with a domed trochlea, no matter what you do physiotherapy wise, you're not going to be able to stabilize that knee. So patient selection becomes really very important. And this paper here by Jack, I particularly like, because it looked at predictors of recurrent patellar instability. So it looked at structural elements and looked at who was going on to redislocate. So the messages are age, and again, Damien mentioned this. So if we've got someone that's 13 or under at first dislocation, they are much more likely to redislocate. And as we've been hearing about the structures, so if they've got trochleplasia and long tendon, again, that really increases the likelihood. And interestingly, if they've had a dislocation on the contralateral side. So these are easy things that we can be looking at to help judge, is this person going to be a good candidate for physio, or actually are the odds against them? So if somebody has all of those three features, they're young, they've got trochlear dysplasia, long tendon, and they've already dislocated on the other side, their actual chance of redislocation is 88%. So we need to understand that. So we need to counsel the patient and parents well as to whether they are likely to respond to rehabilitation. So we need to manage that expectation. And it's certainly a plea to the surgeons listening, please don't use physio as a dumping ground for these patients who really aren't going to respond to rehabilitation. So let's have a look now at this model. Now, interestingly, this model wasn't actually written for patellofemoral pain or instability, but it's a very nice way of framing how I would conceptualize addressing these patients. So let's just have a look at this triangle. So in the bottom right, local stimulation. So in this scenario, we're talking about our trochlear shape, our tuberosity position, our patellar alter, the integrity of the MPFL. But bottom left, regional influences, their hypermobility may be playing into them having an excessively pronating foot. Maybe they have femoral anteversion, or actually their bony rotation might be fine, but they might have, as Vipul alluded to earlier on, poor proximal control of that rotation, or maybe they've got poor trunk and pelvic control. So regionally, what is going on that is creating essentially movement of the trochlea and difficulty in the stability of the patellofemoral joint? And then anyone that has treated these patients will know they have often this omnipresent anxiety about dislocating. It's very difficult to live with this condition. It can be incredibly disabling. And so what is going on there? What are their fears? What are their anxieties? What are their beliefs around this? Perhaps it also impacts, as again we've heard often, there is a genetic element. If mum and dad have had dislocations, maybe a sibling, there's that expectation that this is never going to get sorted. So what is going on in their psyche? And we need to really be mindful of all three elements of the triangle to understand and manage these patients well. So I'm going to start actually with the bottom left, so regional influences. So let's think about planes of movement. So if we think about the frontal plane, first of all, we're not just interested around the knee, we want to come right up to the trunk and think about their trunk control and their lateral spine flexion, because if they're all over the place in their trunk, then that's extra movement that's got to be controlled down to the knee. And in the frontal plane, again, we've heard about this already, hip adduction. So we don't want that functional valgus, we don't want that undesirable hip adduction. In the sagittal plane, we're looking at poor control of terminal extension. So if they can't control from 30 back towards 0, particularly if there's someone with a patellar alter, where they're not going to be getting much stability from the trochlea because their patella is high, that poor control of terminal extension becomes a concern. And then horizontal plane, we don't want the trochlea whizzing around rotationally from poor neuromuscular control. So I want to see that the trunk is quiet. I don't want undesirable extra movement there. I want to see that the femur is only rotating in a way that is necessary and desirable in functional movement. I don't want any more internal rotation than that. And again, at the foot, what's happening at the foot? Is it excessively pronating and creating compensatory tibial rotation that once again provides that horizontal challenge to patellofemoral stability? So can we objectify this? So if we in clinic ask someone to stand on one leg, we can actually start to break it down and objectify this a little bit. And this is Lee Harrington's work, and with permission, this is what he's looking at. He's looking very strategically down through arm strategy. So in other words, are there arms all over the place? Trunk alignment. So as I've said, is the movement in the frontal plane, horizontal plane, coming down to the pelvis, then the thigh. Is the knee position zooming into that undesirable functional valgus inside that second toe in knee flexion? We want that knee traveling over that second toe for optimal alignment. And just generally, how steady are they? Are they having to touch down with the other foot? Are they having to put their hand down? What is this? What is the stability compromise, and where is it happening? Because if we understand where it's happening, then we can target that. And the literature on compliance and adherence to exercise is very clear. When you go above 3 exercises, the chance of them doing the exercises diminishes greatly. So if I try and give an exercise for each of those things, then I've probably lost the patient. So I need to say, actually, this is all about movement, unnecessary movement of the trunk. I'm going to zoom in on the trunk here, or actually it's all around the foot and ankle. Let's target that. So we want to get, so if we look here, these are optimal and suboptimal. So we don't want the arms all over the place, the trunk all over the place. And I show the patients these photos because it helps with that buy-in, that understanding, oh, right, okay, this is why I'm actually coming in with my knee instability problem, but I've been given an exercise to get my back and tummy stronger. So we want to win the patient over so they really understand what they're trying to achieve. And there is literature to back up this neuromuscular training. So we can see that, first of all, if you've got the deficits, what that does. So if we've got weak external rotators of the hip, it correlates with poor landing technique. So people are likely to land and drop into that functional valgus that we really don't want. And conversely, we can see that if we get better glute max firing on EMG, it correlates with a shorter time for deceleration of femoral internal rotation. So that's good. We don't want that internal rotation going on for a long time. We have to have some in the gait cycle, but we don't want long, undesirable patterns. So we can see if we improve gluteus maximus, we shorten that internal rotation time. And also, if we bring in proprioception with strength training, we can't just have the strength alone. We've got to make sure that it's neuromuscular as well. So we're challenging their balance, getting it increasingly harder as we rehabilitate. And that has been shown in this nice paper recently to decrease dynamic valgus. So the take-home message on this bottom left-hand area of the triangle around the regional is the best exercise programs will look at the whole kinetic chain, including the trunk, and include proprioceptive training. Okay, now, orthotics. We've talked a little bit about the foot. So if we see the foot is excessively pronating or wobbling around, should we be addressing that? Well, as everything, patient selection is key. I'm afraid the evidence base is lacking here. There's more around the role of orthotics in patellofemoral pain as opposed to instability. But bringing my experience in here, first of all, orthotics work best for flexible, highly mobile foot. So if you've got a rigid foot, you're less likely to have a good outcome with an orthotic. So actually, those hypermobile patients who've got feet moving around all over the place because they're so mobile can be really good candidates for an orthotic. But I would counsel caution, because if you have somebody with a large TTTG, so in other words, their tuberosity is lateralized, and then you ramp the foot up with an orthotic, which in turn externally rotates the tibia, you will inadvertently actually potentially increase their problem. their relative instability, and certainly often their pain. And I think there are a group of patients that come back and say that they've gone on very badly with an orthotic. And anecdotally, my experience is that when you look, they often have a lateralized tuberosity. So be on your guard for that one. So it's useful sometimes to just see what happens when you correct the foot. Do they feel better? Do they move better? Does it alter muscle recruitment? Does it alter pain? And we've talked a lot about instability, but often they don't come in saying, I've got an unstable knee. They come in saying, I've got a painful knee. So their presentation, their presenting complaint is actually pain. So what happens when I correct the foot? Does it alter that pain? Does it actually increase their apprehension about moving, or do they feel more confident? So that can be a useful thing to do. So coming up now to the quads, we've heard already the importance of the VMO. So let's think about what are the key issues around quads. So right back in 1984, Maria Stokes showed us very elegantly that only 10 mils of fluid inhibits the VM, but the VL, it takes 40 mils. And so patients that have had repeated subluxing or dislocating episodes often, of course, have an effusion, albeit even at a low level. And that just that small amount of fluid may well be driving ongoing inhibition of the vastus medialis, the very thing that they need to be firing well. So look for that effusion. Always, of course, ask, why is there an effusion? Has there been something missed, like a loose body following a dislocation? Because ultimately, they're not that rehabable with a good going effusion. And this lovely paper from Loro recently showed that actually with some patients, if you consider using ice pre-exercise, it seems to get a better response in the quads. They used EMG to look at quads readings. So I think there is certainly a place for that with those patients that are quite shut down and maybe have a trace of an effusion. And the other thing, of course, that we need to be mindful of is pain. So again, it's a paper by Paul Hodges, very elegant study showing injecting saline into the fat pad to make it painful immediately causes delay. And the more pain, the more delay. We've all seen this. We've all seen painful knees that are very shut down, really very atrophied VMO if this goes on for a while. It also helps explain some of the effects of tape. So if you change someone's pain with tape, you immediately increase the firing of their vastus medialis. So tape can be very useful for helping to break that cycle and giving you a window of opportunity with your rehabilitation. Also thinking about time of day, often patients will get more painful as the day goes on, so don't do the exercises when you come in from work and you're painful. And so it supports the use of pain control, and it supports the use of avoidance of pain. In my clinic, I see lots of second opinions, and lots of them have been given very painful squats and lunges, and it just makes them worse and loses their confidence. Closed kinetic chain exercises between 0 and 50 are much less likely to aggravate. And if you have someone that's very nervy with respect to their instability, I'm always very keen on isometric, so static exercises. The last decade, I've been involved with working with an anatomist at St George's in London, and the two of us have now progressed through quite considerable work that's published looking at the architecture of the vastus medialis. And what we found is that sedentary people have a much more vertical fibre, this is vertical relative to the femoral axis, and a smaller insertion onto their medial board of their patella. This can be manipulated with exercise. So when you hypertrophy your vastus medialis, you get larger fiber diameter, which in turn gives you a bigger vastus medialis angle coming in that VMO onto the patella, and it actually also spreads distally with its insertion. So that's what we're after in these patients that ultimately have compromised to their structural stability. I'm after a really effective VMO. So we have to take them to hypertrophy. So our exercises have to be hard enough to hypertrophy them 2 to 3 times a week. And this is all the work we've done. We've shown that closed chain and open chain are about the same. And actually, once somebody gets good gains, and this is particularly important for the stability group, we've shown that 2 exercises taken to fatigue twice a week will hold that architecture change. We've also shown that working with a muscle stimulator is better than closed chain work alone. So take-home messages for the VMO is that atrophy will cause vertical fibres with poor insertion ratio. The exercise can make the VMO more architecturally favourable. And if we have nice horizontal fibres down at around 70 degrees to the femoral axis, that's going to give us our best chance of helping these patients who have structurally compromised stability. And then finally, there's an emerging area now around kinesiophobia. So don't underestimate this fear of movement. And there's work coming through to show that the way people move and jump is actually, particularly in the young patient, more affected by kinesiophobia than actually when we test them, their strength. So what do? We can measure this with the Tampa scale of kinesiophobia, identify the movements that they're most fearful of, so that we can do graded exposure and exercise around those. And finally, taping or not to tape. Well, there's lots of poor evidence around taping, and there's all sorts of different tapes. So what I would say is it decreases pain. Well, we've already said that's a useful thing in quads rehab. And even actually, if you just plonk some tape on a knee, not in any direction, it will improve the way someone moves in a step down task, and it will increase their firing of their sensory motor cortex. So it's a proprioceptive sensory input that improves quads firing. So I do use tape, anything that gives a way in to helping these patients move better and engage with their rehab. So conclusions, I'm afraid the field is in its research infancy, but we can certainly look to get rid of unwanted movement and eliminate it. We can train the quads for structural stability, but considering carefully how we're doing it. And we can tape and brace, and it may well be that it's helping with kinesiophobia, confidence, and patient engagement. Thank you.